Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Ian, so great to have you on the Glenohumeral Gurus podcast for this session. So welcome aboard. It's great to have this opportunity to share your expertise and to really dig into some of those burning questions that I have for you. So I appreciate you joining me for what sounds like it's been quite a busy day at your end. So thanks.
Yeah, thank you. How's things in the future? Because you're already into tomorrow.
Yeah, we're already in the future down here in New Zealand. It's a beautiful day here, middle of summer, so we're having a great time. Welcome to our future. So our plan today then is to, in our first podcast, talk through some sternoclavicular joint, look at your shoulder assessment, all those things that you think are relevant. And then in part two of our discussion, we'll dig a bit deeper into kinetic chain, why you think it's important and why I'm a little on the fence in that space. But before we get started on that, can you share with us your physio journey? How was it that you got to be where you are today?
So it was, I suppose, quite a circuitous route and maybe a lot of serendipity involved in that. I always wanted to be a medical doctor and went on that journey and went to university to do a pre-qualifying year to do medicine, and I actually broke my back playing rugby. And while I was being treated through that, what I noticed was that doctors organised treatment, other people did the treatment, and the people who did most of my stuff at the end of it all were physios. And I thought, that seems a decent job, and I was lucky to then be able to sort of complete my first year in Liverpool and transfer to Manchester and start a physio course.
Okay. And so now, tell me about your day-to-day, what you do day-to-day, just to introduce yourself to the audience.
Okay, so I have a split role, so I work half the week for the UK Sports Institute, which used to be called the English Institute of Sport, where I am what's called an athlete health lead physio with responsibility for upper limb. So we have about 70 physios who work across the institute, and my sort of role is to help with education of and upskilling of the physios who work there, do problem solving with difficult cases, help write rehab protocols, and then get involved when some difficult decisions are required, sometimes around major competitions about whether an athlete will be fit or able to compete at major games when they've got most of the time a shoulder injury or not, and discuss what the implications for that. And then the other part.
How did the interest in shoulders come then in that space? How did that happen?
I when I was at university, I started playing rugby, and then when I changed to do physiotherapy in Manchester, I was on a gym based placement, and the local rugby club came in and said, we want a physio for our club who knows something about rugby. And I was doing well in my placement, and they said, "Oh, Ian's the nearest thing we've got." And I went down to a rugby club with no other medical person there, and learned as I went on, and and enjoyed it. Yeah.
The journey into your PhD, I guess that sort of seems like then a natural segue into rugby shoulders, from what I understand.
Yeah, I mean, I was really lucky then. Through the junior club, I just was fortunate that I ended up working at places and ended up working for England Rugby Union when we had a good team, and we ultimately won a World Cup in 2003. And we did the first injury audit then in professional rugby, and one of the biggest burdens we had was shoulder injuries, but the thing that sparked my interest was something like 72% of shoulder injuries in professional rugby were recurrent. And I thought, oh, why is that then? And I was working with a professor of shoulder surgery in Sheffield, and he said that'd be good for you to do a PhD on. We've seen all these patients together. There's 200 rugby players that you've rehabbed, I've operated on. It'll only take you a year to sort that out. Anyway, 8 years later, I finally finished my PhD.
Want to tell people, we were just chatting about that before, we'll get to sternoclavicular joint, but do you want to tell people then about, we were just talking about proprioception and some of the interesting work that came out of that?
Yeah, so one of the thing we looked at is we know and it's common now that we know that the tackle area is the biggest injury burden across rugby. So we wanted to look at that in detail, but there was very little research done upon the tackle, so we didn't know what muscles worked around there or what happened. So we were able to do a couple of EMG studies, which were really good and reliable data that we got from there. But as a sort of throwaway, we thought we'd have a look and see what tackling did to joint position sense in the shoulder. So we had players who weren't injured, and we simulated a tackle against a fixed tackle bag. They did 10 hits, step and hit the tackle bag. We looked at the joint position sense in mid-range at about 45 degrees external rotation in abduction, and then outer range about 80 degrees of external rotation in abduction. And we looked at their joint position error after tackling. And what we found is there was a significant difference in joint position error. So it was greater in abduction external rotation, or going more to that outer range, so at 80 degrees from there, consistently across the players.
That's fascinating, isn't it? How that's affected. And you were just saying before, we don't know how long then that takes to settle back. Does it settle back within a few minutes, or after the game, or the next day? We still need more work in that space, don't we?
We did one study. A student did one study and got to I think 20 minutes, and it still wasn't back to normal. But within that 20 minutes, that it improved better than before for one measure, but then dropped back to getting further into that external rotation. So yeah, so we don't know how long that takes. And we also tried to look at, was a correlation between the time that you lost joint position sense and the number of tackles made. Was as I say, is it a threshold where once you've exceeded a threshold for proprioception, doesn't matter how many tackles you make, or will one tackle give you 15 seconds altered proprioception to 30? But unfortunately, we tried that with a master's student and we ran out of time and players to do it on. So that's, if somebody wants a big project out there, I'm more than happy for them to take that and run with it.
We take them a year or so. Is that sort of some sort of famous last words?
Yeah, that's right. Yeah, only take you a year. Yeah.
So the other thing I wanted to talk to you around is sternoclavicular joints, and what sort of sparked your interest in this space? How did that happen?
So again, getting that interest around the shoulder, and if you read about the shoulder, the only place the shoulder girdle is attached to the axial skeleton is here at the sternoclavicular joint, which is a joint about the size of your thumbnail. The rest of your shoulder girdle is just held in place by the muscle structure and fascia that's around there. And so thinking, right, okay, let's start at if that's the beginning of the shoulder girdle, we should obviously start from there and see what happens. Plus, looking around, there's very little information about how you assess, how you treat around there. There's quite and even thinking of some of the surgical possibilities, there's not a lot around there. And certainly in the UK, there are not that many surgeons who routinely do surgical procedures on the SC joint.
That's the same here, and they seem to be sort of sent my way as some to try as a last ditch. I can't operate on this person, Margie, what can you do? And so I seem to have quite a few of these on my caseload, in general, I would say they are hypermobile in that they have more flexibility, more laxity in the sternoclavicular joint. The ones that I predominantly see are subluxing anteriorly. That's not the case for you, though, is it? That's not what you think you see. Tell me about that.
Yeah, so most of what I find is that it's hypomobile, it's stiff. So if we look at the sort of the three movements that take place at the medial end of the clavicle and the manubrium, we've got protraction, retraction, so anterior, posterior glide. We've got elevation and depression, and so that inferior, superior glide, and then we've got rotation, which is mainly is posterior rotation. And you know, if we think about basically when we talk about what's happening at the SC joint, we're talking about what happens at the medial end of the clavicle. And so if the medial end of the clavicle can't function, then the lateral end of the clavicle can't function properly. And that means that then the acromion and thus the scapula cannot function properly. And as Paula Ludwig said, is they're phase locked. So what goes on at the SC joint, okay, will affect the scapula. So if you see a dyskinetic scapula, then you must have something going on at your SC joint as well.
Not necessarily. You must, like, a dyskinetic scapula could present for a number of reasons, don't you think? Like, you could have a perfectly functioning SC joint and loss of muscle control.
Again, but that, if you think working backwards, that's going to affect the acromion, which is then going to affect the clavicle as well. So
yes, but what's the chicken or the egg here?
Yeah, again, I think, you know, and for me, if you look at the arthrokinematics, so the movement of the medial and the clavicle with movement, if you assess, most people will say most of mine are hypomobile, you'll find that they haven't got brilliant movement in their SC joint, as I say. And when I'm teaching this on a course and we just go through the assessment and the interventions used, everybody says, wow, that just feels so much easier now. Somebody's had a mess about with my SC joint.
And so tell us about that. How do you assess that? What are you looking for? Because that's not something I routinely assess.
So the good thing is that the SC joint's easy to palpate. You come in from a sternal notch and there you are. And then what I'm looking for when they move in elevation, because the three-dimensional shape of the clavicle, it's the same, it's a saddle shape joint. So we've got from top to bottom that the medial end of the clavicle is concave, and from front to back it's convex. And then if you believe in Kaltenborn's rules for mobilization, so when you get elevation at the shoulder, then the medial end of the clavicle should go down. When you protract, it should come forward, and when you go into elevation, it should posteriorly rotate. And then that's the biggest thing, and that's, for me, that's why the clavicle is S-shaped. Because if we go to the sort of lateral end of the clavicle, where it's concave at that lateral end, when it posteriorly rotates, it lifts up, it's attached to the acromion, and that's what helps maintain your subacromial space. And because this is a lever, a small reduction in movement at this end, if this is the SC joint, is a bigger reduction at this end at the AC joint. So these tiny things that we're not even aware of can have a huge effect on what goes on at AC joint and scapulothoracic joint.
And so how do you know? So you palpate it and then you do some passive testing to affect range and compare to the other side, or
so we compare to the other side and see, but again, we need to find what their meaningful task is. So what movement are they presenting with that gives them discomfort? Okay, so that might be, you know, and generally in clinic, it's going into elevation through abduction, and then we'll have a feel and compare to the other side. And then if we find we've got a limitation of inferior glide or rotation, then we can use bits of manual therapy or some sort of muscle energy techniques to just allow that medial end of the clavicle to move in the planes that it's supposed to do.
Right. So not so much sort of like I was sort of imagining passively inside lying that you're going to then measure range to see if it's affected. How will I know it's affected other than I'm limited, then I mobilize you, then I recheck?
Yeah,
How
so we can do
how
that. Yeah, we can do passive things and feel what happens. But I try and, with everything, find what their meaningful task is. What is it that's brought you here for your shoulder? What is the movement? Right, let's
yes.
have a feel around here. I think I can feel that you are not getting the same amount of inferior gliding, and it might be a millimeter, so it's not massive that we get. It just feels like that. We'll try, and I tend to use muscle energy techniques to start with because they're kinder than the mobilizing from there. And we'll do a muscle energy technique to work into elevation, and then we'll retest their meaningful task. And is it worse, better, or is it the same? And that's what I work on. It will take, if you assess the 3 movements you've got and do an intervention on all 3, it's going to take you less than 5 minutes. And at the end, the worst thing that's going to happen is nothing. But as we were saying, the people on the course
Yes.
I teach all say their quality of movement, if not their actual range of movement, feels better with it.
And we will dig into this more in the kinetic chain thing talk we have, but define then the quality of movement. What does that mean? How do I measure that? Do you know? You're a PhD guy, I'm a
this is the
PhD
problem.
girl. What is that?
Yeah, so I sit in a room, the same room that Joanne Elphiston sits in, and I think that all movement should be beautiful and effortless. Now, quantitative analysis is easy, qualitative is hard, and I work in elite sport and they like numbers, okay,
Yeah.
and I'm a massive outlier from there. But if you're taking your arm out above your head, it should look smooth and a nice rhythm. You can you'll see them that you'll get them to bilateral abduct and it looks like they've got 20 kilograms in their hand as they come around there. That's not, for me, that's a sign of altered motor control with it. And so I look at their quality, ask them to rate what it feels like, and then we'll do something and say, how does that feel? And
Yeah, right.
always going back to the thing that brought them here, their meaningful task. Does that feel better than you did it before? Have you got no pain now? Yeah, with it. Yeah, it's really, really hard, this qualitative stuff, but that frustrates the hell out of everybody I work with in elite sport, because I'm not bothered about strength numbers, because it's about timing and organization of the recruitment pattern as we move. And if the timing of the muscle recruitment patterns are wrong, it doesn't matter whether they're strong or whether they're weak. They're as bad as each other.
Yes, we're going to save that for our second podcast, but I'm looking forward to digging into that with you. And so, just so that I understand what you're doing in the sternoclavicular joint, everybody that you see, or only the people with limitations overhead, you will then assess the SC joint, and if you feel that it's moving differently, mobilize or muscle energy technique to see if you can change that flexion, and you would start there as opposed to starting in the scapula or in the cuff or anywhere else.
Yeah, because as I say, that is the origin for me of the shoulder girdle. And if that is not if that is not working, then it doesn't matter what we do with the other bits. And obviously, when we talk about the kinetic chain, the other bits we need to consider. As I say, it's easy, non-invasive. It takes 5 minutes, as I say, and at the worst, you get no change from there. With it. And I'm a big fan of scapular resting position and all that, but routinely I fiddle about with people SC joints.
Their SC joint. That's going to be maybe the title of this podcast. Ian Horsley, as he fiddles about with SC joints. Can you explain to me scapular resting position? Let's dig into that. What does that mean?
Okay, so for me, I want to see the scapula in an upwardly rotated position. So if we look at the superior angle of the scapula and the inferior angle of the scapula versus the thoracic spine, I want the distance between the inferior angle of the scapula and the thoracic spine to be greater than the superior angle of the scapula and the thoracic spine, because then for me, at rest, yes, because then we are optimizing the position of the muscles that work the scapula and the muscles that are attached to the scapula. Their length tension relationships are optimal, and therefore their movement will be more economical.
And how do you go about that? So you measure that as well then routinely, distance?
Yeah, so generally I eyeball it, but if I need to, so if we're trying to explain to a patient with their permission, then I'll draw on the superior angle, inferior angle, and a line. They can see that it might be parallel. The medial border of the scapula is parallel with the thoracic spine, and we'll look at their asymptomatic side, and they'll see that it diverts away, and we can say, right, that's starting for a position for me that makes it hard for your muscles to operate effectively, because they're disadvantaged, because we were built, our muscles work the best in mid-range, and they're designed to, it's where we spend most of our time, and that's whatever the great creator set like that with it. And if you look, and what I will say to my patients is, if you look around the front, so if we look at the medial end of the clavicle and the lateral end of the clavicle, I want to see that the lateral end of the clavicle is higher than the medial end of the clavicle. And again, in clinic, I use a 2 finger breadth rule, that it ought to be, depending on obviously size of the patient, but there should be a 2 finger breadth difference. I think radiologically it's 19 degrees or something they talk about, but I'm not doing that. So I can get them
their
to see
fingers or your fingers.
My fingers roughly. So obviously, if somebody's bigger, small, I can roughly, but you can see that their resting position, and you can show them that. And then when I'm teaching them to do stuff to try and optimally get the resting position of the scapula better, they've got some feedback at the front about being able to upwardly rotate and not elevate with it.
Okay, there's lots in there, isn't it? Because while I pay attention to their position, I guess I'm way more interested in their strength and control through range, rather than particularly their resting position. I have a personal bugbear around the scapular setting that for some reason in our world seemed to mean that we were retracting and downwardly rotating, which is absolutely not where we...
Yeah, setting's a bad word. I don't let anybody use setting because of that. It's not retracted and downwardly rotated, because that is what puts you in a bad position. And so if you're downwardly rotated, we need 60 degrees of scapular upward rotation. If you're downwardly rotated 10 degrees, then you're expecting the muscles to produce 10 degrees more upward rotation than they were designed to do. So that's never going to work. Yeah. So setting, I banned from everybody who ever speaks to me.
So on that, I think we can agree, but you're talking about then resting position, which is
because it's a dynamic movement. As I say, if you think what I'm explaining it is, if you're having a party and you're having jelly and ice cream, you make your jelly and you put your hot water in, and then you pop it in the fridge, and you have to wait for the jelly to set. Okay, and you're going from something that's liquid with your hot water and mobile to something that's more rigid from there. So that connotation, same setting, is a static thing, and I've seen patients come in and said, I've got to put my shoulders back and down, keep them there, and then put my arms up above my head. And you're going, I wonder you're not getting any better with it. It's like, once you have positioned your scapula, forget about it. It should sort itself out. Not set anyway.
But I guess what we can agree is that scapular setting, that it's a dynamic control situation that we're looking for.
Yeah, that's right. Yeah, it's a position. Yeah, we want to position the scapula in an optimal position, and then it has to move. It has to be able to move from that position.
Okay, so let's wrap up some of this sternoclavicular chat. If you see then you have assessed them, you see that they're limited over range, you change their SC joint, and that improves their range up overhead. What does that mean for you? What does your treatment plan then look like?
So again, because I'm a great believer in motor control and muscle re-education and patterning and engrams, then it's a lot. I will just get them to repeat that movement while it feels good, because that should be enough. Then from what we've done, if we whatever freed, optimize the movement, then the joint will move. The joint will move because joints are better when you move. You've got that hyaluronic acid the synovial fluid in there that lubricates, so the joint feels better. You get better quality, low friction, less pain, and brain's going, oh, I love this. Yeah, no, I like that. We'll just carry on. It usually doesn't take many. Well, maybe one session will do, most possibly two. I don't have to spend a lot of time once we've freed it off, whatever that means. And that could be because we've got an elevated first rib behind it, which is then stopping the clavicle from posterior rotating. So we have to deal with the elevated first rib and do what we need to find out, why is that? Is it because of suboptimal breathing that's created that elevated first rib? We can use an MET to release that. Then we need to make sure anterior middle scalene's got good extensibility, so it can stay down there. We might teach them to stop breathing apically and get them a better breathing. So again, it's the next thing where if we see something like that, or it could be hypertonicity of subclavius, that muscle that we all forget about, and it does very little. It stabilizes the SC joint. It's an accessory movement muscle of respiration. So again, suboptimal breathing, that can recruit it, but that's not going to then elongate and let the clavicle posterior rotate. So again, we'd have to work on something like that. So it's about going to the next thing. So why I've found that. Why is that? Let me get to the why, rather than just thinking right.
Yeah. Which is so I used to think that I could change people's patterning in particularly in shoulder instability, and then once I'd changed their patterning and built up their strength, that strength would last, and therefore their patterning would stay the same, and their shoulder would be cured, to say. That's no longer my belief, because I think, like we say, these patients come back, they need additional strengthening, they need to reinforce that pattern. Do you see these, I guess what I'm thinking of, these stiff SC joints? How long does that last for? You think you just move and then you learn to move differently and then you're okay in that space?
So in my experience, it does. Obviously, half my job I work in I'm working in elite sports. So we've done stuff with some of our elite women gymnasts. So we've done a functional test with them, and then mowed that whatever we needed to do around their SC joint, and that's been enough to sort things out, really. But then it's about seeing if there's anything else from our posture wise or movement wise, things that could be responsible for that with it, because
which is facilitating that.
Yeah, because a lot of them
that then you address.
Painful. Yeah. So I find them, but because I'm looking for them, not because they're saying it's sore or it feels stiff or anything. It's just because I routinely assess them, as I say, and always have a fiddle with them, and the worst that happens is nothing. Yeah.
Do you have any closing remarks? Anything you want to share with clinicians about why they should do that, and what you think is important about that?
So for the SC joint, as I said at the start, it's the only place that the shoulder girdle attaches to the axial skeleton from there. And it's important because we talk about the SC joint, but it's about the clavicle, and that clavicle attaching to the acromion, which attaches to the scapula. So for non-traumatic AC problems, a lot of the time it can be sorted by normalizing, optimizing movement at the SC joint. With it, as I said, it'll take you 5 minutes to look at it and have and try some things on it, and the worst that can happen is nothing. If you've got a high hypermobile one, which we've not spoken about, then as I was saying when we were chatting earlier on, so I've only seen it apart from the one that my wife's got in adolescent females, and that has been, I've been able to stabilize that or get them to be less lax by sorting out scapulothoracic motion, so control of the scapula and of the thoracic spine to change that, and that the link earlier on that we talked about. So yeah, just have a look.
I mean, they do seem to be connected there in that space, don't they? I think about the hypermobile EC joints that I've got on my caseload right now that are sometimes sitting, in that thoracic flexion and anteriorly tilted, downwardly rotated. And I seem to be able to relocate them when I sit them up straight and posteriorly tilt and elevate the scapula. That's been my experience in that space. Do you have any gems there for me on the hypermobile sternoclavicular? They're tricky in my experience.
Yeah, so the hyper one, the most important thing is that it's much less of an issue if it's anteriorly unstable. If it's posteriorly unstable, then that's an issue. I have seen 2 of those, the traumatic posterior subluxations actually, that I had to go to hospital as an emergency because you've got some quite important blood vessels around there. So anterior ones are a little bit disconcerting because you can see it, that certainly the ones I've seen have not been related to pain. It's been more that, look at this with it, but like yourself, by optimizing scapulothoracic control, that has seemed to be successfully enough for the people that I've dealt with to get control, apart from my wife, who's got to have a resection of the medial end of her clavicle.
Okay, so what I'm going to take from this is I'm going to start assessing what happens at the sternoclavicular joint particularly, I guess, in my AC joint people, who are limited overhead, and then see if I can actually affect some change there. That's your take home then for clinicians here, eh?
Yes, yeah, I think so. Because you're coming over to England later this year.
Yes, I am.
We can go through some stuff in Sheffield. Well, looking.
Yeah. I was just talking with Val about confirming that. So that'll be really nice to meet up with you and put that together.
Yeah, okay.
Cool. Thanks very much. Thanks for joining us for this podcast. I hope you really enjoyed it. As Ian and I were saying, I'm going to be in Europe in September. We've organised a one-day shoulder course on behalf of USA on the 6th of September, and this will be in Sheffield, and Ian will be assisting me. So I hope you can come join us there. See you then. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well. Take care.